Thank you, Dominic, and thank you, Andrew, for that. And thank you also for doing some slides that Peter Doran, who's ill, unfortunately, was to speak to. So we appreciate that, and for writing them over lunchtime. I'm going to touch on aspects of types of trial design as distinct from trial design. So Andrew mentioned the randomisation, and we do have a session tomorrow. Is she still here, Erica? Yeah, so Erica's going to talk about randomisation tomorrow in much more detail, so I'm not going to talk about it here. And there are other components that are spread out either through today or tomorrow that I'm not going to touch on. And the purpose of this talk is just to introduce you to the different types of trial design that are available. And this is only some of them, some of the more common ones. There's a lot available. And it's by no means that you go away knowing the nuts and bolts of each of these design types, but you'll just think maybe there's a little bit more out there than the traditional parallel group randomised control trial. Simply that. Is that okay? Sorry, thank you. So we'll talk about various trial designs, and we know that choosing the appropriate design is crucial if you want to get reliable results, depending on the question you're asking. And the types of designs I just want to briefly, and again, it's just introduce you to the concept of them, are a few. And again, those of you who do know trial designs, and there are people in this audience who know them very well, these are just a selection, but they're probably the most common selections, I think. So we have the randomised control trials, which many people are familiar with, the non-randomised trials, depending on what that means. We've adaptive trials, which I'm not going to talk about at all because that's coming up, well, I mentioned it, but Alistair's going to talk about that tomorrow. We've crossover trials, cluster randomised trials, factorial trials, hybrid trial designs, N of 1 trials, step wedge trials, master protocol trials, registry-based randomised control trials, and most trials, multi-phase optimization strategy trials. Hands up who's heard of all of those. I knew there's 3 or 4 of you who picked you out, yeah. And these are those people. There are more. Okay, many more. But these are the most common ones. So for the rest of you, it'll be maybe an introduction to some of the designs and just maybe start thinking about them. And what I want to try and introduce is what they are, what the key features of them are, and just highlight some key advantages and disadvantages to them, perhaps. Is that okay? Depending on your question that you want asked. That's all. I'm trying to set the expectations here that this is just an introduction for you. But before we kick off, just remember that when we're thinking about a randomised trial, it does come back to basics. It does come back to what's your research question. What's the objective that you want to achieve? What question do you want answered? It really does come back to that. And often, and colleagues in Galway know this, when we sometimes have a question we want asked, it literally is sitting around the table with blank page and saying, this is where the uncertainty is. See, can we articulate that uncertainty really, really clearly? And it's literally blank page. What might the design, best designed to fit on this then? And often it's adapting designs to fit the questions, not changing questions to fit designs. And that has pushed the methodology on. Factors that influence the choice of design type might be also feasibility and practicality constraints. There might be lots of really good ideas to go down a particular route, but due to feasibility and practicality constraints, and that could be financial, it could be temporal, time available, it could be due to the population of the sample, the population in which you want to draw your sample from, it could be due to the health systems, infrastructure, lots of changes to design types during COVID. Lots of studies that had kicked off, and so many of you may have been involved in these, where there was a rethink of some of the designs due to massively altering clinical care pathways for lots of patient and client groups. There might be ethical considerations. So my background is maternity care and midwifery, and still today, if you pick up anaesthetic journals, they're talking about and the impact or the effectiveness of the impact of epidurals, for example, during labour and its impact on mode of birth. You'll find lots of people say it's no impact, and you'll find equally lots of studies saying actually it does have an impact. That if you have an epidural, that you increase the likelihood of having a cesarean section, and other studies saying no, etc. And the reason there's such ambiguity out there, that we haven't yet done the large randomised trial where we randomise half of the women who want an epidural to get it, and the other half don't get it. And you can imagine why. Okay? Now, it's not unethical to do it if women were agreeable to participate in it and were genuinely given, as Lydia said, that good information and make an informed consent, but you're probably going to have recruitment problems along the way. And therefore we've had to rely on other design types to inform decisions on this. And then the generalizability and the it needs to be considered. The ability to generalize the results of a study to a broader population beyond the sample in your particular study. And that can be influenced by lots of factors, including the population, the study design, the intervention itself, and the outcome measures. One of the big things, and it's getting a lot of conversation at the moment, is what do you think is one of the big factors influencing generalizability of randomized trials today? What do you think is there's a lot of conversations around it. What could you do as a researcher to limit the generalizability of your trial, or conversely to increase it? What do you determine? The inclusion-exclusion criteria, don't you? That diversity that you want to accommodate within it. The extent of narrowness of your inclusion-exclusion criteria. That geographical diversity, ethnic diversity. Degree of acuity of the condition, diversity, etc. So many times you'll see, traditionally, it's moving away from it, but if you're one of the following people, you're excluded. You know, if you've got a mental health illness, if you're pregnant, if you could be pregnant, if you, all of these different things that, you know, were just blanket exclusions which limit the generalizability of some of these studies. So these things all need to be borne in mind as you're considering what design might be most appropriate for you. So I'm going to start off with the first one, and I just put some content in the slides. I'm sure everyone here is aware of this, probably the easiest of them in some ways. It is the easiest of them, I think. So just because of the diversity of the audience, so randomized trial is a study design in which participants are allocated to two or more groups, usually an intervention and a control group. And the control group could receive allocated to two groups. It could be two interventions technically, and often it is, or it could be, more traditionally, it would be an intervention and a control group. The control group receives standard care or placebo if it's a drug trial, etc. And the key features of a randomized control trial in the context of how I'm describing it, it's the optimal design for evaluating the effects of healthcare intervention. We're not saying it's I dislike the hierarchy of evidence entirely. It's a bugbear of mine. I think it's ridiculous. That hierarchy of evidence that we have, the pyramid, applies to the effects of healthcare interventions. There's lots of other. So is a systematic review of high-quality randomized trials going to tell you anything about the social impact of chemotherapy for breast cancer in women? No. So it's useless for that. So we need to be thinking about, again, what's the best design for the question I want to answer. And for evaluating the effects of healthcare interventions like the epidural, the randomized trial still is the best. I'm not saying we'll get it done, and that causes some of the problems. Key features of randomized control trial is obviously randomization, and randomization numbers two components, which actually I'm going to stop. Will be covered much better tomorrow. Fair, okay. Blinding, often randomized trials consider blinding, and they consider three levels of blinding in many trials. They consider blinding of the participants, they consider blinding of the personnel involved, and blinding of the outcome assessment to minimize detection bias. Most of us, I think, discourage using single, double, and triple blind trials because there's good evidence that they mean different things to different people, and you can have different combinations of double blind, and it doesn't really mean very much. So it's better just to articulate who is blinded and to what. So the advantages are it's got high internal validity. It therefore minimises bias, and I'll show you why in a second. And they can lead to relatively easier interpretation. One group gets an intervention and the other doesn't. What happens in the outcomes that we look at post a time period? Disadvantages is they can be costly, they can be time consuming, and again potential ethical concerns as to whether you can do a randomised trial or not, as we spoke about and I will speak about shortly. And Andrew's given good examples, I think, of as to why some drug trials do cost a lot of money. They cost a lot of effort and staff time, take a lot of effort to integrate with care pathways. And where systems, for example, lack digitisation, healthcare records in Ireland are largely manual records. Many of your clinical background, lots of healthcare systems are still very manualised. We don't have a single unique record identifier. So that increases the burden and the cost of accessing data. So again, that can be some of the disadvantages when you still have to adhere to good practice in conducting your trial. So you can see a very simple diagram. You've got your study group of people who are randomised into one of two groups or more. And the idea being that if you randomly allocate a sufficiently large enough group of people, that the characteristics that may affect the known characteristics and unknown characteristics or factors that may impact on the intervention will be evenly distributed between the groups. And therefore, when you measure the outcomes down here or compare the results, if there is a difference in the results, you would hope that after randomly allocating sufficiently large number of people, adequately randomising them, that you would be able to demonstrate that any difference in the results is attributable to the intervention and not to something else that's going on. And that way it minimises bias. Oh, I don't know why it's coming up like this. Sorry, no idea why they're coming up like this. Anyway, so non-randomised controlled trials. So in the context of this, is what I don't want to do is, and by the way, some people do, and they're not wrong, but I don't want to create an impression that there's randomised trials and then non-randomised trials is everything else. Observational studies, studies with a control element to them, etc. So the approach I've taken, and lots of other people take, but not everyone, is that you've got randomised trials and then you've got non-randomised trials. And the difference between them is, in a non-randomised trials, it's the same, except the way you allocate the people to the groups isn't truly random. Does that make sense? Yeah. Literally, that's the only difference I'm describing in the definition I'm using. Because there are other observational studies, but there are other controlled trial designs that I want to go through also. So lots of people would say that, don't try to lump everything other than the RCT under an umbrella heading called non-randomised trials. So I'm not going to go through that, and it's just literally the randomisation component doesn't use truly random means of allocating participants to the groups. So examples of we'll hold again, Eric will cover that, I'm sure. So crossover trials is, a crossover trial is a type of randomised trial where each participant gets both the treatment and the control, but they get randomised to which sequence they get. Do they get the control first, or do they get the intervention first, or do they get, for example, medication A and B? Do I get medication A first, or do I get medication B first? A time period happens, and they swap over. If I got A, I now get B. If I got B, I now get A. So here's an example of it. So you've got people are randomised in to receive a particular intervention. There's usually, they take that intervention for a period of time. There's usually outcome assessment here. Yeah? Because that outcome assessment point will tell you the differences between the groups in outcomes at this point in time. You then look at a washout period where you want the effects of the intervention to have washed out of the person. If it's a drug, for example, to have washed out of the system, the body system, literally. And then they cross over. And now you're going to get medication, they're the wrong way around, as you can see here, the labels. So this should medication A and is going to go on to medication B, and medication B is going to go on to medication A. Okay? Does that make sense? Yeah? Okay. One of the challenges of one of these, they're a really good design because everybody's acting, within subject design it's called, everybody's acting as their own control. So in effect, you need a smaller group of people to give you a higher precision in this particular trial. But they have got challenges also. So one of the things here is in many clinical conditions we have, the condition needs to be really stable because these randomizations and the crossover is happening over time. So they take the intervention over a period of time and you measure the outcomes. And you have to wait a period of time for washout, and then they're now crossing over to get what they hadn't got initially before you measure the outcomes again. Does that make sense? So 2 periods of outcome assessment here and down here. If the condition isn't stable enough, then the people may have deteriorated differently anyway, and nothing to do with the particular intervention that they got. Does that make sense? So it's really suitable for some chronic illnesses, particularly you see it being taken, that are subject to slow or relatively stable chronic conditions, subject to slow change. Yeah. Okay. Apologies, this is coming up differently, but these will be there in your handouts cleanly like this. So a cluster randomized trial then is a design in which instead of randomization occurring by randomizing each participant to get an intervention or a control, you're randomizing groups of people. So that might be, trials we've been involved in have been GP practices, the full GP practice, so therefore all of the patients within that practice who meet the inclusion and exclusion criteria will get randomized to the intervention or to the control. So a study we were involved in, for example, pulmonary rehabilitation program for people with lung disease, chronic lung disease, whereby you go to, let's say, 50 GP practices and you've got this really cool pulmonary rehabilitation program and you want to evaluate its effectiveness for people with lung disease. So you could randomly allocate entire GP practices to get the pulmonary rehabilitation program or not. And within each practice then, you want each practice to recruit people who meet your inclusion and exclusion criteria with COPD. Yeah? So, and often you have 2 levels of inclusion and exclusion criteria. You often have inclusion and exclusion criteria at the cluster level. What does a GP practice look like? Is it a single GP? Should it have a computerized medication system? Should it have a computerized healthcare record, etc.? And then you've got the inclusion criteria for the people with whatever you're looking for. So in this particular case, they have to have lung disease. How's lung disease diagnosed? By spirometry, whatever else it may be, or blood gas levels, or whatever else it might be. So you have 2 levels of inclusion and exclusion criteria. Other ones we've been involved in has been schools. We're randomizing entire schools to receive an intervention. Yeah? Or not receive the intervention. For example, an education program to see what effect it might have. Very popular design. Because you're randomly allocating people, whole groups of people together, it's more likely that those people share some characteristics. And this can give rise to what's called an intra-class correlation coefficient, and Eric and Darren and others can talk about this much more than I can. But you need to, that similarity of characteristics needs to be considered in your sample size estimations for a cluster randomized control trial. Because you're not randomizing individual people, you haven't got that high variability, you've got more similarity going on. And that's measured by a thing called ICC interclass correlation coefficient. And the higher that value is, the higher your sample size usually will be. Yeah. So very popular design, cluster randomized trials, particularly in interventions in primary care and at public health care levels, and in education. So here is a traditional randomized control trial, randomly on the left, randomly allocating participants. This person is randomized to here or here, In the cluster, groups of people, or schools, or GP practices, or regions of large countries, counties it could be. Factorial trials, lots of papers written on these and around that we don't use them enough, and they're a really efficient trial design. Wow. Okay, really efficient trial design. I'm going to some of the diagrams then, okay? So a factorial trial allows you to test different interventions and levels of intervention simultaneously. So here, for example, you've what's called a 2 by 3 factorial design. And so you've got two numbers here, a 2 and a 3. So I know that I've got I've got two factors because I have two numbers. That's the first thing. First factor here is the solution. Is it soap solution or saline? The number is 2. I've got two types of irrigating solution. By 3, my second factor is irrigating pressures. I've got 3. 1, 2, 3, 1, 2, 3. How many groups will somebody be randomized to? If I'm up here now, and I'm going to be randomized, 6, isn't it? Yeah. If I did 3 by 3 design, if I had 3 irrigating solutions here, 3 by 3 design, 9, etc. Yeah. Okay. So it allows you to test the different levels of the levels of the intervention, for example, or different factors within the intervention simultaneously. Hybrid trial designs are something I find it incredibly hard to get my head around because there's such a continuum of them. From something that looks almost like a piece of implementation work, post the trial having been conducted, to something up at the other end which looks like a traditional randomised trial. But effectively, most hybrid trials tend to come in when you've got some evidence of effectiveness, you need some more, and you're also trying to evaluate the implementation of the trial simultaneously. So therefore, they're often mixed methods. They often have a component of a randomised control trial and a component of, for example, even qualitative or observational type work going on simultaneously. N of 1 trial, so this is a randomised trial with just one person in it. How good is that? Yeah. It depends on who you ask, probably. But so this is where a person is usually in rare diseases. It's very personalised, where you're usually randomising treatment components to the person over periods of time and evaluating outcomes in that person after each randomisation step. But each person could be randomised multiply to different levels. Stepped wedge trials are a really cool design, I think. And I believe the stats are just coming, the lot of work on the statistical analysis of these in the last 5 or 6 years I've seen. But concrete example, you've got a piece of kit or technology or test that's being rolled out into the system. People love these new tests. And an example we have is where in maternity care there was a new diagnostic test that we knew clinicians were going to use, very little evidence how effective it was going to be. 20 maternity units, it was 19 maternity units, let's say 20 maternity units in Ireland. You randomise which unit is going to use it first, it starts using it. So start the trial, you had 19 units not using it, 1 unit using it. You then wait the next number of weeks or months, and you've randomly allocated who's the next unit. The randomisation will tell you what is the second maternity unit that's going to be using it. So you keep doing that over a period of time and evaluating the outcomes at each time and point. By the end of the trial, you have 20 units using the new intervention that possibly would be used in the system anyway. Okay, I'll stop at this one. Master protocol is just 3 different types of master protocols. Alice is going to touch on this one tomorrow. But a master protocol is trying to be, lots of vaccine trials are set up like this, where you've got a large protocol, standardized protocol, and within that you can have, for example, different diseases but the same intervention being targeted at different diseases. You can have the same disease but different interventions being targeted, for example. And the master protocol would serve as the framework within which all of these trials would be conducted, with a sub-protocol then written into it for each of these trials individually, but refer back to the master protocol, in this case, for example, because the disease setting, inclusion exclusion criteria might be identical. Does that make sense? So often used, and we see them now in vaccine trials. And just because of time, I'll stop there, but you can pick up on the other two design types then at the end. Thank you.